Assalamu alaikum wa barakatuh. Before starting our session today, I will show my YouTube channel. This is very important for everyone want to pass SCE or European board. Just search for Suhaj Endocrine Group. This Suhaj Endocrine Group in the YouTube. This is my channel. In the playlist, you will find a subcategory SCE and European Board 2020. This contains every previous session, and this contains, I think, about 200 or 300 thousands of hours, 200 to 300 hours of interactive discussion. In the previous, every session we discussed previously is uploaded in this YouTube. You can, for example, this is the last one in the previous week, inherited endocrine syndromes. And also you will find another one I will show, for example, this is a gonads question discussed in the previous year with my colleagues, Dr. Ibrahim, Dr. Mahmoud Izzat, Dr. Nayera, and everyone. Also, this is a very huge contents to everyone. This is a diabetes session. So just go to the Suhaj Endocrine Group and go to the SCE and European Board playlist. This is very important. Every session after, at the end of the day, I upload it to this channel. Today, inshallah, this is the 5th session in diabetes mellitus topics. And I think we have only one session to finalize the diabetes mellitus topic chapter. Inshallah, in the next week, I will finalize the diabetes mellitus and finalize the dyslipidemia in the next week. And after that, we have only a chapter of gonads. It may take 1 or 2 sessions, inshallah, and a final session to discuss some topics in Oxford book. Today, inshallah, we will discuss microvascular complications from Oxford handbook. But before starting, we all must memorize Dr. Mahmoud Izzat, Dr. Ibrahim Al-Ali, Dr. Hussam Hosni, Dr. Sameh, Dr. Hamdi Al-Qadi, Dr. Abdurrahman Shalabi, Dr. Khaldoun, Dr. Sufyan, Dr. Ala, Dr. Mustafa, and a great one, Dr. Rupan Khan and Dr. Iman, Dr. Asma, Dr. Nayera, Dr. Rana, Dr. Najah, Dr. Ilham, Dr. Gopta, and Dr. Yasmin. And also a lot of members, sorry if I forget anyone, but a lot of my colleagues making this activity alive. So إهداء ليهم كلهم في قلبي وكلهم هم أصحاب الفضل في اللقاءات دي. Especially Dr. Nayera in the previous year, she has the first اللبنة الأولى في الموضوع ده كله كان من خلال الدكتورة نيرة. شكرا لهم جميعا. It is very important for everyone prepare for subspecialty examination and European board how to study. This is just summarize what is the important topics to review and to study before the examination. Actually, I think the next examination in December, I think everyone must prepare well for these topics. The Oxford Handbook of Endocrinology, the third edition, is the most important book to review and to study. And actually, in our sessions, we already discussed most of the topics of this book. We already finished thyroid, pituitary, adrenal, parathyroid, and the diabetes, inshallah, in the next presentation, in the today session and the next session, we will finish diabetes. The only part we need to finish is the reproductive endocrinology. Also, a tool book, which is the best of 5 book, is a very important book. This is a book of a tool book, best of 5 MCQs for endocrinology and diabetes SCE. This book contains about 319 questions, a very important book to study before the exam. So everyone prepare for next exam or next July exam. Try to study well Oxford Handbook and a tool book. Another question, you must try to prepare for solving MCQs, and the most important websites to study is StudyBRN. I just mute some ones. Okay. And websites that contains a question for subspecialty examination, StudyBRN is the most important one. And also I prepare PDF files that contains every question in this size. But for everyone, if you can pay for this website, try to pay for it. If you have but you can at least study from the PDF files. You can print these files and study from what you print. Also, another very important source is Exam Lab. Exam Lab, it just contains about I don't memorize nowadays. It contains 100 or 200 questions. Very important
200.
One to study. One or two?
200.
200, okay. And also I collect the question of Exam Lab and put it as a PDF file. You can print it and use it freely. In every exam, about 25 to 30 questions from the Exam Lab. Typically questions, they take the same scenario and same options in the same order. And another very important website to study is the website MCQs in the European Board and Subspecialty Examination, MRCB UK website. They contains some sample question, and I also collect this sample question and put it in a separate PDF file. Another one, which is a British Medical Journal on Examination website for subspecialty examination, contains about 800 questions, and also I prepare it in the 2018 years, and I put it as a PDF file. Another one, which is the Practical Diabetes website, and also we must review all the guidelines, especially British guidelines, NICE guidelines, and Joint of British Diabetes Societies. And after that, European Society of Endocrinology, European Thyroid Association guidelines, if you have a time. But the most important guidelines is the NICE and GBDS guideline. GBDS, it is a Joint of British Diabetes Society. It contains for diabetes and diabetes emergency, hyperosmolar hyperglycemic state, DKA, renal disorders and diabetes, inward management of diabetes. It have a lot stroke. It have a very important guidelines which needed in the exam. And also the NICE guidelines, the most important NICE guidelines, primary hyperparathyroidism, diabetes with pregnancy, type 2 diabetes, diabetes with during in children, and also DEVLA guidelines, which is very important in the exam. And the
دكتور
last
حضرتك كنت عامل محاضرة عن الجايد لاينز، هل دي
yes
كافية؟ كانت حوالي 5 ساعات هي،
yes
ولا لازم نقراهم بالتفصيل؟
this is a summary for this guidelines. If you have no time, just review this session. It is about 5 hours in the previous year. If you have a time, try to review these guidelines, but I think it is very sufficient. I prepare it very well. I summarize all the guidelines which you need in the exam. And last thing, MRCP part 1 and part 2, endocrine question is very important, especially for part 2, because it is difficult than part 1. So try to solve a question of past test or past MRCP or on examination for part 1 and part 2 MRCP. And also, of course, past medicine. And also I actually collect this question and put it as a separate files. If anyone wants this PDF files, it is all available in the WhatsApp group, Telegram group, in the Facebook group. And if you send to me a message, I can send a link which contain all this material. This is a very important how to study and how to prepare yourself to the next exam. I will remove my video. Okay. And actually, this slide I put it before our exam in the previous years, 7 days before exam. During that time, we discuss a lot of material, but I advise everyone, and I am one of them, what we should do 7 days before the exam. What is the most important to memorize? I asked everyone to study exam lab several times. Try to solve it at least several times. Don't miss any question in the exam lab. And the next one, try to review best of the 5 Atul book, not the question, but also the comments prepared by Prof. Atul. And also try to review SCE and European Board website questions. And also I prepare recall for previous 3 years examination, and also I put it, and we have a lot of sessions in the previous year discussing this 3-year previous examination, and also try to revise the guidelines. And as one doctor mentioned, we have already a session about 5 hours discussing the most important guidelines for the exam. And if you have a time, try to review Oxford Handbook, rapid revision. And if you have a special notes and algorithm and image, try to review it 7 days before the exam. This is what you should do before 1 week before the exam. So I hope everyone to pass the exam. And actually, in our previous group, I think everyone is passed. 2 ones is not passed, but مستواهم بصراحة كان رائع، بس لظروف معينة ما عدوش لأن كان عندهم تجهيزات للحياة التانية. Let's start our session today, inshallah, about the microvascular complications of diabetes. If anyone want any question in the how to prepare for the exam, it is welcome. الناس المحتاج بالفعل اشكرها كتير في كل مره، وليهم افضال كتير على المجموعه دي. ما ننساش الدكتور محمود عزت، الدكتور ابراهيم، الدكتور سفيان. اكرر الاسماء دي عده مرات لان بالفعل في السنوات السابقه كان الدسكشن بتاعهم مثري جدا، خاصه الدكتور محمود. الدكتور ابراهيم من الناس البايونيرز بصراحه في اندوكراين، الدكتور سفيان، الدكتوره نيره، الدكتوره رنا. شكر كتير خاص، انا بكرر شكري ليهم لان بالفعل هم اصحاب الفضل في الموضوعات دي. And inshallah today or tomorrow I can upload my own Oxford Handbook which is highlighted. my PDF file of Oxford Handbook, I just highlight the most important topics like this, and I just prepare it from my book. Let's go to diabetic eye disease. We have, inshallah, today I will summarize diabetic retinopathy and diabetic kidney disease and neuropathy. وعليكم السلام.
الحمد لله.
الدكتورة سمر، الدكتورة انتصار.
ايه اللي تاخده؟
I mute them. I will answer some question. Dr. Al Ibrahim, excuse me, Dr. Khalid, in exam lab PDF, no explanation of the answer. Is it same on the website also? Yes, it is not explained, but actually in the previous year, we already discussed exam lab with Dr. Mahmoud Izzat, Dr. Ibrahim, Dr. Nayira, Dr. Arana, Dr. Sufyan, and we put explanation for this question. Actually, we already answered this question, and we have a lot of discussions for explanation why this option is the correct one and why other option is not correct. So try to review our previous explanation for exam lab, and also every topics, for example, study BRN, we solve a lot of questions from study BRN, and actually we have a lot of interactive discussion about this question. So try, if you have a time, try to review this materials. Can I get the link for PDF? Of course, Dr. Arasi, please send to me on the WhatsApp, and I will send you all PDFs. Dr. Ruben, are you see my screen or not? Dr. Ruben, send a private message. Sir, I cannot see the screen. Is it okay, Dr. Ruben Khan, or not?
Assalamu alaikum, Dr. Khalid. Yes.
Okay.
Yes, alhamdulillah, now I can see. Yes,
nice to see you and hear from you, Dr. Ruben. You are a great one.
Thank you, Dr. Khalid. Thank you, Dr. Khalid.
Actually, in the exam, diabetes chapter have the most of question in the exam. It contains, I think, about more than 30% of the questions. I think it is 38%. And it is classified as diabetes classification, and another one for diabetes emergency, and another one for diabetes complication. And some of question is very difficult, and some of question is very easy. So inshallah, today we will discuss diabetes microvascular complications. Diabetic retinopathy is a complication of diabetes resulting from damage to small blood vessels, generally occurring 10 years after diabetes onset. And 10 years after diabetes onset, not the diagnosis of diabetes, because actually, if we diagnose diabetes today, the insult start at least from 7 years ago. So once you diagnose diabetes today, type 2 diabetes, try to search for microvascular complications. Diabetic retinopathy is the leading cause of blindness worldwide. Cataracts also are more common in the people with diabetes. And of course, diabetic retinopathy is extremely common with long duration of diabetes. So in type 1 diabetes, the recommendation is start to screen for diabetic eye disease after 5 years of diagnosis in type 1. In type 2 diabetes, is screen for diabetic complication once you diagnose type 2 diabetes mellitus. Diabetic retinopathy, the prevalence is about 35% in all diabetics. About 7% had a proliferative diabetic retinopathy, and 7% have a macular edema. Actually, these numbers in the exam, they may ask about these numbers. And a 10% had sight-threatening diabetic eye disease, which is one of the diabetic emergency. As we know, type 2 diabetes is a progressive disease. Once you diagnose type 2 diabetes, you must start for screening for microvascular complications, because the beta cell insult is start 10 years earlier, and actually macrovascular complications may be started before the diagnosis of type 2 diabetes. So the macrovascular complications, try to search it once you diagnose it type 2. The risk factor for diabetic retinopathy usually is the age, the duration of diagnosis of diabetes, diabetes control hemoglobin by hemoglobin A1C, the blood pressure control. This is a 4 risk factors for type 2 diabetes, and actually this slide is very important. It mentioned, it is from website, diabetes duration, if more than 20 years of diabetes, the risk of diabetic retinopathy is more than 76%. If hemoglobin A1C is more than 9, risk of diabetic retinopathy is more than 50%. The blood pressure control is protective. If the patient is hypertensive, the risk of retinopathy is increased, and also some race and ethnicity group have a more risk of diabetic retinopathy. Dr. Suhail, is my slide appear well or not? Dr. Suhail Ahmed?
No, Dr. Khalid.
Is it okay, my slide, or?
No, I can see only your picture.
No, I think, is this is for Suhail or for everyone? My slide, my presentation.
السلام عليكم دكتور خالد.
وعلى سكاته.
السلايد واضحه يا دكتور، ما فيهاش مشاكل.
I think Dr. Suhail is a problem in your computer only, or try to exit and enter. I think everyone see my slide, my presentation on my screen, and also my image. I remove my video.
Okay, I will do it.
Okay. Okay. Thanks, Dr. Korben. Okay. I try in my this presentation. I just go to the chatting. Okay. I try to collect a lot of slides because in the exam they may give a fundus examination and ask about it. This is the normal retina. You must memorize some of it. Of course, this is the optic disc. This is one of the optic disc. I think you can see my mouse pointer. This is the disc. And from the disc, two vessels, retinal artery and retinal vein. The most apparent one is the retinal vein, and the one is which is not pulled is the retinal artery. This area is the macula. The central one is the fovea, and the around it is the macula. This is the macula. So don't forget, this is the optic disc and this is the fovea and the macula, because we will discuss maculopathy, the disorder of this port. One of the most important topics you must review and study well, the classification and feature of diabetic retinopathy, because actually in the exam they give a scenario, and for example in the scenario mentioned that there is a hard exudate and ask you to classify this, which is it a background retinopathy or pre-proliferative retinopathy or proliferative retinopathy or maculopathy, for example, or is it R1 or R2 or R0 or M1 or M0, for example. So try to study it well. The background retinopathy or R1, it is a microaneurysm, and I just give a fundus examination for microaneurysm. This is a microaneurysm. And another one, it may be a hemorrhage like this. This is a hemorrhage in the fundus examination, or hard exudate like this. This is a hard exudate, or soft exudate or cotton wool spot like this. In any fundus examination, if you see microaneurysm or cotton wool spot or hard exudate or hemorrhage, it is a background retinopathy or R1. And in the exam, they will ask about when to do another retinal examination if you find a hard exudate. Okay, try to study this classification very well. And this is also a background retinopathy. This is a hemorrhage. For example, this is a hemorrhage. This is microaneurysm, and this is exudate. And of course, this is the optic disc, and this is the macula or fovea and macula. And this is another one, which is a preoperative retinopathy or R2, graded as R2. In the preoperative retinopathy, multiple plot hemorrhage like this. This is a plot hemorrhage, which is, if it is a multiple plot hemorrhage, this is preoperative. Or IRMA, which is intraretinal microvascular abnormality like this. This is the IRMA. Venous beading like this. Venous beading or venous reduplication. So the hard exudate, it is a background retinopathy. But the multiple plot hemorrhage, it is a preoperative retinopathy. A dot hemorrhage, it is a background retinopathy. IRMA or venous beading or venous reduplication, it is a preoperative retinopathy or R2. A very important one is proliferative retinopathy, R3. R3 or proliferative retinopathy, it is a new vascularization. A new vascularization in new vessels, a new abnormal vessels. If it is presented around the disc or in the disc, it is called new vessels on the disc or NVD, like this. If new vessels apart elsewhere from the disc, it is called new vessels elsewhere, like this. Actually, it is a proliferative retinopathy. If it is a new vascularization in the disc or apart from the disc, it is a proliferative diabetic retinopathy. Another one, if you see vitreous hemorrhage like this, it is a proliferative retinopathy. It is emergency. If we see in the scenario Rubus iridis plus or new vascular glaucoma, it is a proliferative retinopathy or 3. So the most important in the proliferative retinopathy is a new blood vessel formation, a new blood vessel formation or vitreous or preretinal hemorrhage like this. It is R3. Maculopathy, it is a diabetic maculopathy which will affect the macula. This is the macula, and graded as M0 if no maculopathy, or M1 if there is a maculopathy. So it is M0 if normal macula, M1 if there is a maculopathy. Maculopathy means any exudate is like this. I will show the exudate like this hard exudate, but this exudate within one disc diameter of the center of the ovea, like this, in about this distance. If there is exudate in this area, it is a maculopathy. Or a group of the exudate within the macula, or any microaneurysm or hemorrhage within one disc diameter of the center of the fovea, only if associated of best visual acuity of less than 6/12. So if in a scenario mentions that there is a microaneurysm or hemorrhage, it is a background retinopathy. But if he mentions that a microaneurysm or the hemorrhage within one disc diameter in the macula, it is not a maculopathy except if it is associated with visual acuity of less than 6/12. Okay, so the microaneurysm, it is a background retinopathy. If it is within the macula and visual acuity is diminished, it is a maculopathy. A retinal thickening within one disc diameter of the center of the fovea, if stereo available, this is not very important. And this is also an image which summarizes R0, which is a normal retina, which is a normal diabetic retina. R1, which is a background retinopathy. And this is another classification. Classify R1 as a moderate, and an R2, which is a severe non-proliferative diabetic retinopathy. But I think the Oxford Handbook classification is very well in the exam. And of course, R3 is a proliferative diabetic retinopathy, which contain a new vascularization or vitreous hemorrhage. And other classification for retinopathy are 0 if no retinopathy or other non-diabetic lesions are seen, for example, macular degeneration or Drazen maculopathy. It'll be with evidence of a previous laser, photocoagulation, so P photocoagulation, and U if unclassifiable. This classification is not very important in the exam. The clinical and histological feature of diabetic retina, one of the first histological change seen is the thickening of the basement membrane and loss of pericyte embedded within it, and may ask about what is the first histological change that occur in diabetic retina, loss of pericyte embedded within it. Thickening of the basement membrane and loss of pericyte. And this led to increase in capillary permeability, and also microaneurysm is the hallmark of retinal microvascular disease in diabetes, because this is the background retinopathy, and as we know, the progression from a background to R3 is a progressive diabetic eye disease. The background retinopathy, it is just as we mentioned, it is a cotton wool spot or a dot hemorrhage, and this is capillary microaneurysm, or the earliest feature seen clinical as red dots or dot hemorrhage. And actually, we mentioned it a lot of times in the previous slides. A preparative retinopathy or R2, this is a multiple plot hemorrhage or IRMA, like this, or venous bleeding or venous reduplication. Try just to know it and how to diagnose it. And if you find this image, for example, and actually in the exam they didn't mention it is venous bleeding and ask about how to classify it, it is preparative retinopathy or R2. And the yearly treatment of diabetic retinopathy study mentions that if you try to manage this retinopathy early as possible, you can avoid, of course, the blindness. If you have one of this feature, you can, which is, for example, 2 quadrant IRMA or 1 quadrant with venous bleeding, the progression in risk of developing of proliferative retinopathy is about 15%. If 2 are represent, the risk rise to about 45%. Proliferative retinopathy, it is a vitreous hemorrhage like this, or a new vessel formation like this. And of course, as we mentioned previously, if the new vessel formation around the disc, it is called the new vessel on the disc. If it is elsewhere, it is called the new vessel elsewhere. And don't forget that proliferative retinopathy, the most important modality for treatment is periretinal photocoagulation. Periretinal photocoagulation will reduce the 2-year risk of severe visual loss by about 50%. Don't forget this percent. Reduce of 2-year risk of severe visual loss by about 50% or more. And the presence of preretinal or vitreous hemorrhage and untreated eyes with high risk criteria had between 25 to 36 chance of severe visual loss within 2 years. Proliferative eyes, if untreated at 2 years, a risk of the severe visual loss will be 7% after 2 years. And after 4 years, it increased to 20%. If treated, a risk of severe visual loss will decrease to about less than the half of these numbers. Diabetic macular edema, as we know, that this is the macula, and this is a macula in another section. Diabetic macular edema or maculopathy may be classified into focal or diffuse and ischemic types. 3 types of diabetic macular edema: focal, diffuse, ischemic. الفوكال maculopathy it is succinate pattern of exudates around ischemic maculopathy focal coagulation. The early treatment of diabetic retinopathy study reported that also focal here it is a focal photocoagulation, but in the proliferative retinopathy we use pan-retinal photocoagulation. In maculopathy الfocal photocoagulation of a clinical significant diabetic macular edema substantially reduce the risk of visual loss, and also which is and this is also another fundus examination demonstrates the hemorrhage, exudate which is a background retinopathy, microaneurysm which is a background retinopathy, optic disc, and of course this is the fovea, and exudate in the fovea mentions that this is a maculopathy because there is exudate within the macula. And this is the venule, and this is the one which is not appear as a venule. The most apparent one is the venule, and this is the arteriole. Eye screening is very important, and as recommended by the guidelines, the visual acuity by Snellen chart is one of the most important method to assess the visual acuity. Eye examination and fundus examination, we must visualize the fundus by dilatation of the pupil by tropic made 1% before examination. Also, a very important slide in the exam and in the book, when to refer to the ophthalmologist. This is very important actually, because in the every exam they will ask a question from this slide. Reason for and timing of referral is a question in every exam. When to immediately refer your patient if you see rubus iridis or neovascular glaucoma, vitreous hemorrhage, advanced retinopathy with retinal detachment, you must refer your patient immediately. So in the exam may ask give a scenario, and in the scenario they mention that there is a rubus iridis, and in the option ask when to refer this patient to ophthalmologist. In the rubus iridis or neovascular glaucoma, vitreous hemorrhage, advanced retinopathy with retinal detachment, you must refer your patient immediately to avoid vision loss. Another one, when to urgent referral your patient, and urgent referral means refer your patient within 2 weeks. In a case of RS3 or proliferative retinopathy, you must refer your patient urgently. This means within less than 2 weeks. A routine referral, you will refer your patient if a pre-proliferative retinopathy R2, like venous bleeding, for example, or IRMA, or M1, which is maculopathy. You must refer your patient by routine referral, which means within less than 13 weeks. Routine non-diabetic retinopathy referral for cataracts, and of course in other category, if there is no retinopathy, you need to do annual screening. In a case of background retinopathy, just annual screening and informed diabetes care team. This slide is very important. Try to memorize the classification, R0, R1, R2, R3, and maculopathy. And another very important slide, when to refer your patient to ophthalmologist. This is very important. The most important slide in my presentation is this slide. How to treat a diabetic eye disease? Of course, the medical treatment is very important, and the most important one is glycemic control. And according to the EBEEDM study and DCCT trial, they mentioned that if you try to improve hyperglycemia very rapidly, it will worsen the diabetic retinopathy. The most important step in diabetic retinopathy is long-term diabetes control. Actually, in our practice, we see a lot of patients who have a diabetes since 20 years, and today presented to my clinic by diabetic retinopathy, and his hemoglobin A1C is more than 10. Don't try to normalize the blood sugar within a few weeks. The main problem is occurred if you try to rapidly control hyperglycemia, diabetic retinopathy will be worsened. Also, in the pregnancy, diabetic retinopathy will deteriorate. So in our previous presentation about the management of diabetes during the pregnancy, and especially the guidelines published by the NICE in 2015, it is a very important guidelines to when to screen for diabetic retinopathy during the preparation of a pregnancy and during the pregnancy. And this is very important because in the exam they will ask about when to screen for diabetic eye disease during the pregnancy and preconception. And also diabetic kidney disease is very important, especially during the pregnancy. So the glycemic control is very important for management of diabetic retinopathy, but the blood pressure control is more important than rapid control of hyperglycemia. A good blood pressure control is vital to reduce the onset of diabetic retinopathy. Also, statins is very important because elevated serum lipids are associated with macular exudates, and they try to prescribe statins. And also fenofibrate from the field study mentions that diabetic retinopathy is improved by prescribing fenofibrate. The antiplatelet therapy is not needed for diabetic retinopathy, but the most important step to know, statement to know, that an antiplatelet therapy is not a contraindication if the patient have a proactive diabetic retinopathy. If the patient need antiplatelet, and don't forget that an antiplatelet is not routinely prescribed for a diabetic patient except if there is a serious cardiovascular disease, risk of coronary heart disease. This is the only indication for antiplatelets. Previously, we prescribed antiplatelets for for every diabetic patient, especially the elderly one, especially if he have another risk factor like hypertension or smoking or family history of serious cardiovascular disease. But nowadays, there is no rule for routine antiplatelet therapy for diabetics except if there is a cardiovascular need for it. A lifestyle advice is stopping smoking may reduce the risk of diabetic retinopathy, especially for in type 1 diabetes, not type 2. A risk factor for developing or worsening of diabetic retinopathy, it is classified as modifiable risk factor for diabetic retinopathy, like glucose control, systemic hypertension, blood lipids, smoking in type 1. And non-modifiable risk factor for diabetic retinopathy, duration of diabetes, age, genetic, ethnicity, and pregnancy. This is a non-modifiable risk factor. المodifiable, we try to modify it and treat it as early as possible. The surgical treatment of diabetic retinopathy, we have two modalities for surgical treatment: a laser treatment, and another one which is a medical treatment with each intravitreal injection, and another one which is vitrectomy. A laser treatment, actually in the exam, they will ask about a laser treatment. One question in our previous question asked about the complications of periretinal photocoagulation. Don't forget, this is a fundus examination, and this is a dots for periretinal photocoagulation. Don't forget, this is a sum. Hence, usually the treatment performed in 2 or more episodes, no more than 2 weeks apart. Most of patients have at least needs 2 sessions. They usually require a local anesthetic drops. And this is a types of laser photocoagulation. It may be focal like this for focal maculopathy. It may be grid laser if there is a maculopathy, or may be periretinal laser photocoagulation like this for proactive retinopathy. In our patient, there is a new vessel on the disc, or pre-retinal hemorrhage, or pre-retinal. This is a laser scar for periretinal photocoagulation. Don't forget this. Laser treatment for clinical significant macular edema reduce vision loss by more than 50%. Laser treatment mainly don't regress or improve or يعني ايه يرجع الامور لطبيعتها. الليزر treatment aims to prevent the further vision loss. Once a part of the retina is lost, الباريتينال photocoagulation, the main aim is to prevent the further vision loss, not to restore the vision. It is aimed to prevent the further vision loss. And also don't forget that if the patient moves his eye during the therapy, it may lead to accidental burns to the fovea, and this is a very serious complication. In our exam, they ask about one of the most important side effects of pararetinal photocoagulation, which is a reduction in the night vision. In night vision mainly depends upon the periphery of the retina, these pores. And if we do pararetinal photocoagulation, we will focus on the periphery of the retina, which will reduce the night vision. So the most important side effects of the pararetinal photocoagulation is the reduction in the night vision. Another one, which is surgical treatment, which is vitrectomy. It is needed, especially in the advanced diabetic retinopathy, especially if there is a severe vitreous hemorrhage. When we refer our patient for vitrectomy, the reason why vitrectomy be required: a non-clearing vitreous hemorrhage, a large subhyaloid macular hemorrhage, a tractional retinal detachment, combined retinal tears or tractional retinal detachment, progressive severe fibrovascular proliferation, or some types of diabetic macular edema. Another very important alternative for surgical treatment is the use of intravitreal VEGF inhibitor. And of course, VEGF available in 3 drugs or 3 drugs. The most important one, which is bevacizumab, which is Avastin, and it is used as intravitreal injection. And another one, which is begabatinib, and another one, which is ranibizumab. This treatment is recommended in a certain case of diabetic macular edema. So for diabetic macular edema, the most important first choice is laser photocoagulation. If the patient have a contraindication, we can use intravitreal VEGF inhibitor. Some regression of new vascularization and reduction in fluorescent leakage, but don't forget one of the most critical complication of anti-VEGF drug is potential complication of endophthalmitis and retinal detachment. رايح فين؟ One of the most potential complication of anti-VEGF drugs is endophthalmitis and retinal detachment, because as we know, this image, it is a just intravitreal injection of a drug, and this injection can introduce some infection and lead to endophthalmitis. And another one, cataract extraction, it is not very important, but you must know that there is a higher complication rate than in the non-diabetic population. And this is just two slides from the, I think, IDF guidelines for diabetic retinopathy. This is when to use a laser treatment and when to use anti-VEGF. A laser treatment mainly can prevent the vision loss and stabilize the vision if performed early. It is indication focal treatment, which like this for focal diabetic macular maculopathy, and a grid laser can be used for maculopathy. This is not the first choice. First choice is photocoagulation. And also, this is a laser treatment. This is the first choice. This is the laser treatment. This is the first choice for diabetic maculopathy. Pararetinal photocoagulation, it is the first choice for proliferative diabetic retinopathy and pararetinal treatment selected case of severe non-proliferative diabetic retinopathy. And don't forget the potential complication, loss of the peripheral vision or and reducing night vision. This is the most important one. And this is the anti-VEGF injection. The indication is diabetic maculopathy, and in some case of proactive diabetic retinopathy of if photocoagulation is not available or not have a contraindication for it. And potential complication, conjunctival hemorrhage, endophthalmitis, retinal detachment, and don't forget the contraindication, ocular or periocular infection, contraindication to anti-VEGF injection. And this table, I don't know from which textbook I copy. This is just the grading of diabetic retinopathy. Don't forget that R0, which is normal retina, R1, which is background, R2, which is preparative, R3, preparative retinopathy, and maculopathy M. If there is a photocoagulation, it is a B, other lesion O, unclassified U. This table is very important. Try to memorize it because in the exam they will mention, for example, there is a multiple deep round or plot hemorrhage and hard exudate, and ask you to classify it as which are, and may ask about a referral for this one. And this just some of fundus examination image. This is a macular degeneration. This is a macular degeneration, dry or wet. Just try to know this image is a wet macular degeneration. And this is one in the my program. I don't memorize from which question bank. This is, of course, this is exudate in the macula, so this is a maculopathy. And this is another one. This is a macula, and this is just a plot hemorrhage, and this is the ERMA, which means preparative retinopathy, multiple plot hemorrhage, not one plot hemorrhage, multiple plot hemorrhage. And this is the ERMA, which also is a preparative retinopathy. And this is also another fundus examination, which is show the ERMA, the exudate, which is a hard exudate. This is a hemorrhage. This is a pigmentation from the previous laser treatment in the macula. And this is a laser pairs. This is a laser pairs. And this is a just microaneurysm, which denotes background retinopathy. This is another ERMA. And this is another slide for venous beading and ERMA. This is the venous beading, like this, and this is the ERMA. And this is a cotton hole spot. And some of dark plot hemorrhage. To differentiate between, this is preparative diabetic retinopathy. We finish diabetic retinal disease. We will go to the next most important topic in microvascular complications, which is diabetic renal disease. A diabetic kidney disease or diabetic kidney disease, this is the recent name, or diabetic renal disease or diabetic nephropathy, is the major cause of end-stage renal disease and dialysis worldwide. About 50% of the patient on renal replacement therapy due to diabetes. In many Middle and Far Eastern countries, about more than 20%. In the UK, the majority having type 2 diabetes. But don't forget that 50% of the patient on dialysis due to the diabetic renal disease. In definition, diabetic nephropathy is defined by the presence of devastating positive proteinuria in a person with diabetes. Try to memorize these numbers a lot. You will have a lot of numbers in for diagnosis of micro and macroalbuminuria, for albumin to creatine ratio, for urinary protein ratio. This equates to an albumin concentration of 300 milligram per liter, which equivalent to total protein 0.5 gram per liter. So, albuminuria, which is 300 milligram per liter, equivalent to total protein 0.5 gram per liter. Excretion rate between 20 and 200 micrograms per minute are called microalbuminuria. Don't forget this, and I will mention later on. A lot of units used: milligram per liter for albumin, a gram per liter for protein, microgram per minute for microalbuminuria excretion rate. And everyone have a different numbers. A chronic kidney disease have been classified into stages according to the estimated GFR, which is the glomerular filtration rate. Normally, GFR is more than 90. If the GFR is more than 90, this is G1. If there is some imaging or some laboratory showing microalbuminuria or imaging modality showing diabetic renal disease. Stage 1 and 2, stage 1 if GFR more than 90, stage 2 G2 which GFR between 60 and 90, G3 if the GFR between 30 and 60, G4 between 15 and 30, and G5 if the GFR less than 50. This is how to classify chronic kidney disease according to the GFR, and this is very important. How to estimate the GFR? We have at least one simple equation, which is Cook-Croft-Colt equation for estimation of GFR in milli per 1 minute. It is just 140 minus the age multiplied by weight over 72 multiplied by serum create. But don't forget that is serum create here by milligram per deciliter. This is for male to estimate the GFR. If our patient is a female, we must multiply the result by 0.85 if the female. So this is a simple equation to estimate the GFR. This is not a very accurate formula, but it is a simple one, and everyone can try to use it in her private clinic. Another very important one, which is more accurate than Cook-Croft formula, which is MDRD equation, and another one which is EBEEDM equation. This is a computerized program or a smartphone application. It is if you try to find MDRD equation, you will find a lot of applications. Just you need to print the choose serum create and the age, and if it is a male or female, and the computer will or smartphone will show the estimated GFR. Of course, the most important risk factor for development of diabetic kidney disease is the duration of diabetes. Is the major risk for development of nephropathy. And don't forget, actually, in our previous exam in the previous year, they asked about one of these numbers. They asked about the percentage for development of end-stage renal disease in type 1 diabetes after, I think, 10 or 20 years of duration. So in our previous exam, they asked about the percentage of development of end-stage renal disease in a patient with type 1 diabetes after 20 years of diabetes duration. For end-stage renal disease, the rate is 2.2 and 7.58 have recently been reported from the Finland after 20 years duration. This is for type 1. And for type 2, this is the end stage occurring 0.6% after 10 years. So try and memorize this number at least. For type 1, it is 2.2 after 20 years. And it is 0.6 for type 2 after 10 years. This is the percentage of development of end-stage renal disease or need for dialysis. This is the definition of nephropathy based upon albuminuria. Of course, microalbuminuria or macroalbuminuria or clinical nephropathy. It is classified according to FU overnight collection, the reference range by microgram per minute. And if you do 24-hour collection, it is milligram per day. If you do albumin concentration, it is by milligram per liter. If you do albumin to creatinine ratio, it is by milligram per millimole in Europe, and it is by milligram per 1 gram creatinine by USA reference range. So we have a lot of reference range. You just need to try to know one. Actually, in the exam, they will show the normal reference range. If they mention a microalbumin, a patient with albuminuria, for example, they will mention albumin to creatinine ratio. It is, for example, 20, and they will mention that the normal reference range between 2.5 to 30 for males or females. And don't forget that the albumin to creatinine ratio is a reference range is different in males than in females in the European reference range. But actually, in the American Diabetes Association, they mentioned that the microalbuminuria is just between the normal microalbuminuria, albumin to creatinine ratio normally is less than 30. Between 30 and 300, it is microalbuminuria by milligram per 1 gram creatinine, and macroalbuminuria if albumin to creatinine ratio is more than 300 milligram per 1 gram creatinine. It is milligram albumin per 1 gram creatinine. And this is how to classify according to the GFR. If the patient at risk for development of diabetic kidney disease and no albuminuria, but a patient is diabetic and GFR is more than 90, this is a stage 1 diabetic kidney disease. If GFR between 60 and 90 and the patient there is no albuminuria, it is a stage 2 chronic kidney disease. If GFR is reduced and there is a microalbuminuria, so this is a diabetic kidney disease, and for stage 4 and 5. And actually, in the latest guidelines published by American Diabetes Association, they put this diagram. They classify here GFR, this one, and this table mentions the albuminuria if it is normal albuminuria or microalbuminuria or macroalbuminuria. According to GFR, they mentioned the patient is a chronic kidney disease, treat or not treat, and when to refer to the nephrologist. For example, if we have a patient with GFR, for example, 50 GFR. So this is a GFR, so it is a grade 3A. If the patient has no albuminuria, we must give, we must treat this patient, and we must redo the testing with one per year. If the patient have a microalbuminuria, it is more critical. We must treat and we must do screening and examination twice per year. And if for the same patient, GFR is 50 and there is a macroalbuminuria, in this situation, we must refer this patient to the nephrologist and we must review our patient 3 times per year. This table actually is very important and summarize a lot of topics in the diabetic kidney disease.
Dr. Khalid,
yes,
can you
Dr.
go back to this? Can you
yes.
go back to this chart? What is this green 1 if CKT and 1 if CKT? I didn't understand this. 1 and this 2.
Because
yes.
If the GFR is 90, for example, 100, for example, is this a chronic kidney disease or normal? If we have another imaging modality showing that his kidney is abnormal, In this situation, we label this patient who have a GFR 100, which is normal, but the imaging study showing that this kidney is abnormal. In this situation, this patient must be labeled as a chronic kidney disease, and we must reassess this patient after 1 year. Okay? In this situation, GFR more than 60, for example, Dr. Ruben. In this situation, even if there is no albuminuria, we can classify it as a chronic kidney disease if there is evidence of imaging abnormality mentions that this kidney is diseased. Okay. How to make diagnosis of diabetic kidney disease? The most important to memorize albumin to creatinine ratio is a mandatory. Remember to exclude the potential confounding cause of positive test of albumin to creatinine ratio, because if there is a vigorous exercise, if there is a urinary tract infection, if there is a presence of blood or menses, or there is a concentrated urine, this may give a false positive albuminuria. So during estimation of albumin to creatinine ratio, we must look for urine analysis. If there is over-the-count pus cells, this albumin to creatinine ratio is invalid. And one which can give a false negative test for albuminuria is dilute urine, less likely using albumin to creatinine ratio, because albumin creatinine ratio, it is just a random spot sample, not a 24-hour urea collection. Actually, we can estimate the albumin to creatinine ratio, but a lot of methods, but the simplest one is a random spot sample. Don't forget that if there is a rapidly developing nephrotic range proteinuria or accelerating loss of GFR more than 5 milli per minute per 1 year, this you must note that this may be not a diabetic kidney disease. Try to search for non-diabetic cause for this rapid deterioration of the renal function. So if there is a nephrotic range of proteinuria, we have two very important categories. One of proteinuria due to the diabetic kidney disease, and another one proteinuria to a non-diabetic kidney disease in a diabetic patient. If there is a nephrotic range of proteinuria, a huge proteinuria, this is actually mostly not a diabetic kidney disease. It is a nephrotic syndrome in a patient with diabetes. It is a nephritic syndrome in a patient with diabetes. So try to refer this patient and try to search for the cause. If there is a rapid deterioration of the GFR, which is more than 5 milli per minute per year, for example, if we do an estimated GFR since 2 years, and it is an 80%, and after 2 years it is a 30%, it is a rapid deterioration of the GFR, so search for a non-diabetic cause. If there is a presence of a feature of other systemic disease, for example, if there is a urinary RBCs cast in the urine analysis, so it is mostly a non-diabetic kidney disease and it is a nephritic syndrome. Or there is accelerated hypertension, try to search for alternative cause for this cause. Pathology, I think it is not very important in the exams, but we must know that the earliest pathological feature in type 1 diabetes is a kidney enlargement. And don't forget that the echogenicity of the kidney by ultrasonography usually appears normal during abdominal examination, even if the late stage of diabetic kidney disease. And actually, the kidney is enlarged in the early stage of diabetic kidney disease due to the tubular hypertrophy and hyperplasia. And this is the first stage called hyperfiltration stage. Within 5 years of type 1 diabetes, small but significant increase in glomerular capillary basement membrane thickness. And don't forget that diffuse glomerulosclerosis and nodular glomerulosclerosis is one of the illest manifestation of diabetic kidney disease. This is just image for normal kidney glomerulus and diabetic kidney glomerulus. It is not very important, but it is just, if anyone want to study it, I will put it. Don't forget the false positive results of albuminuria is very important clinically in your clinical practice. Vigorous exercise, urinary tract infection, presence of blood or menses, concentrated urine may give a false positive results of albuminuria. Don't forget GFR is very important. Older people with type 2 diabetes may have chronic kidney disease due to other non-diabetic kidney cause like hypertension or neurovascular disease. Albuminuria associated with a gradual loss of GFR, the rate of the increase of albuminuria is heavily influenced by systemic blood pressure and dietary protein. The blood pressure is very important to control the blood pressure, and don't forget that what is the blood pressure targets, and every year the guidelines is changed, but according to the NICE guidelines, the recommendation is if there is a diabetic kidney disease, the target blood pressure is systolic 130 and diastolic is 80 millimeter mercury. In cardiovascular disease, mortality is increased at least twofold for patients with microalbuminuria, and annual mortality of 2 to 4% for those with microalbuminuria due to the cardiovascular disease, nearly 20% in those who with serum creat more than 175 micromole. Don't forget that this is the serum creat by UK units, 175 micromole per liter, and or renal replacement therapy. And or a treatment of diabetic renal disease, try to control the blood glucose, try to control the blood pressure, which is mandatory and very important, the cardiovascular risk factors, and the diet. This is a for glycemia, blood pressure, risk factors, and the diet. The glycemia, don't forget that a good glycemic control can prevent the development of microalbuminuria, and even with the microalbuminuria, and if you try to tight control the blood sugar and blood pressure and the risk factor, it may reverse to normal albuminuria. The GFR declines, insulin clearance by the kidney is reduced, so doses may need adjustment. Don't forget that insulin clearance, endogenous insulin is cleared by the liver, but exogenous insulin is cleared by the kidney. This is very important. So in any patient with type 2 diabetes or type 1 diabetes on insulin therapy and the GFR is declined, needs a dose adjustment for insulin to avoid the hypoglycemia, because exogenous insulin is cleared by the kidney. Endogenous insulin is cleared by the liver. This is very important. The blood pressure, as we know that RAS blockade, renin angiotensin system, and RAS blockade drugs, ACE inhibitor in type 1 and the ARBs in type 2 is very important. Diabetes and renal guidelines suggest a target blood pressure is less than 130 over 80 millimeter mercury in patients with diabetic nephropathy. And don't forget that statins need LDL cholesterol less than 2 millimole per liter. This is a very important number. This is the target according to some guidelines. Another guidelines, they have no LDL targets, just a non-HDL cholesterol, and some guidelines, American recommendation, high intensity statin or moderate intensity statin according to the risk factor. And don't forget that the diet, dietary protein contents less than 0.8 gram per kilogram is suggested for established nephropathy. And actually this number is not, some recent papers don't suggest this except in advanced nephropathy. So the protein restriction is not needed except in advanced nephropathy. And another very important topic in diabetic kidney disease, when to refer to the nephrologist. And according to the NICE guidelines, they recommend referral of all patients with a chronic kidney disease stage 4 if GFR less than 30 or worse. So if GFR less than 30, refer your patient to nephrologist. All those with a rate of progression within 2 years or rapid decline of GFR more than 5 milli per minute per year, this need a referral. Complication of chronic kidney disease like normocytic anemia, secondary hyperparathyroidism, or unusual features suggestive of non-diabetic kidney disease, for example, nephrotic range proteinuria, or signs of non-diabetic kidney disease, or rapidly decline GFR, this need referral. And this table summarizes the criteria for referral for specialist review. Chronic kidney disease stage 4 or 5. Rapid decline of GFR if there is a GFR decline more than 5 milli per year or more than 10 milli per 5 years. And actually in our previous exam, they ask a question about this. And microscopic or macroscopic hematuria, this need to exclude the nephritic syndrome or active sediments, urinary sediments, this need a referral to nephrologist. Signs of other systemic disease like systemic lupus manifestation or systemic sclerosis, blood pressure outside the target in spite of 4 or more drugs at optimum titration needs a referral. Heavy proteinuria more than 1 gram per day or protein to creatine ratio more than 100 milligram per millimole. Don't forget the reference range. Family history of genetic disease, as we know that the polycystic kidney disease is autosomal dominant. Once you see a polycystic kidney disease, you must refer your patient to nephrologist to search for polycystic kidney disease. If we suspect a renal artery stenosis, in this scenario, we must refer our patient to do some radiology scanning or to search for a cause for renal artery stenosis. And this actually from the guidelines published by the NICE, this is a guideline about chronic kidney disease in adults, assessment and management, published in the July 2014. They mentioned when to refer, actually take into account the individual wishes and comorbidities. People with chronic kidney disease in the following group should normally be referred for a specialist assessment. GFR less than 30, as we mentioned, albumin to creatine ratio 70 milligram or per millimole or more. We mentioned it here, heavy proteinuria, or albumin to creatine ratio 30 milligram per mole or more, together with hematuria. It must be hematuria. Sustained decrease of GFR, hypertension that remain poorly controlled in spite of 4 antihypertensive drugs, known or suspected rare or genetic cause of chronic kidney disease, suspect renal artery stenosis. This is just, we summarize it in this table from the Oxford Handbook, and this is the guidelines published by a NICE guideline. A chronic kidney disease in the adults assessment, how to pharmacotherapy blood pressure control in people with chronic kidney disease, aim to blood systolic less than 140 milligram millimeter mercury, less than 140, and diastolic less than 90. This is for chronic kidney disease only, not diabetic. But if the patient is a chronic kidney disease or diabetic kidney disease, the blood pressure must be systolic less than 130 and the diastolic less than 80. This is for chronic kidney disease, not diabetic, and this is for diabetic kidney disease. How to choose an antihypertensive drug? They mentioned that offer a low-cost renin-angiotensin system antagonist to people with chronic kidney disease. If the patient is diabetic, we must give renin-angiotensin system antagonist. If the patient is hypertensive or the patient albumin to creatine ratio is increased, we must give renin-angiotensin system antagonist. Don't offer a combination of ACE and ARBs, of course, as this is from several years actually. Follow the treatment recommendation in the hypertension, and we must, I think in our previous session about the guidelines, we discussed hypertension guidelines published by the NICE. This is the second most important topic in our session today, and this is the last topic we will discuss, which is diabetic neuropathy. diabetic neuropathy, one of the most difficult topic today is diabetic neuropathy. Definition: it is involvement of cranial, peripheral, and autonomic nerve. It may be diffuse and may predominantly, of course, diabetic neuropathy, mainly sensory diabetic neuropathy, mainly sensory, not motor. And it may be acute or chronic. It may be transient or permanent. The commonest clinical consequence of a neuropathy is altered sensation for pain and may increase sensitivity to the normal sensation. A neuropathic ulcer, which affect the feet, erectile dysfunction with autonomic neuropathy, erectile dysfunction, one of the autonomic neuropathy, and Charcot arthropathy, which is a very common in the exam. Pathology as diabetic retinopathy and diabetic kidney disease, it is a microvascular complications. It is mainly a pathology. Distal axonal loss occurs with a focal demyelination. Also, vasa nervosum often shows a basement membrane thickening, endothelial cell change, slowing of the nerve conduction velocity, or complete loss of the nerve function. So nerve conduction velocity will be decreased in the diabetic peripheral neuropathy. Pathogenesis due to the hyperglycemia, which although another risk factor like hypertension and dyslipidemia, leads to a lot of change in the glucose metabolism, leading volatile. This is not a very important biochemistry actually. The classification of diabetic neuropathy, it is mainly sensory neuropathy, which may be acute or chronic, and autonomic neuropathy, which is erectile dysfunction and gastroparesis, or posture hypotension, and how to manage it. And actually, in every exam, they ask a question about the gastroparesis and how to manage it. The mononeuropathy, don't forget, this is it is diabetic peripheral neuropathy, but affect just one nerve. Intraptum neuropathy or external pressure pulses or spontaneous mononeuropathy. And don't forget that proximal motor neuropathy with diabetic amyotrophy is a very common in the exam. Peripheral sensory-motor neuropathy, chronic sensory-motor neuropathy is the most common feature of peripheral nerve involvement. At least 50% of these patients are asymptomatic. Most of the patients with diabetic neuropathy is symptomatic. Prevalence increase with increasing duration of the age, as all of microvascular complications. 7 to 8% of the type 2 patients have abnormality at diagnosis, and 50% can be expected to have them 25 years later on. The feature of peripheral sensory-motor, usually insidious onset. Usually the onset starts by numbness or paresthesia. It starts in the peripheral toes and on the soles of the feet. This is the starting point, not a start from the hands. It is a start from the soles. And it is a symmetrical fashion. It is usually symmetrical. So it is insidious, numbness and paresthesia, start in the toes and the soles of the feet, symmetrical. Affects all sensor modalities. Reduced vibration perception threshold. This is a very important, and this is one of the earliest manifestation of diabetic peripheral neuropathy, is loss of vibration perception threshold, which can be done by 128 tuning fork. And another one, penny prick, fine touch, temperature sensation. This is the earliest manifestation of diabetic peripheral neuropathy. Decrease in vibration sensation and absent ankle reflexes are often the first feature found. Another risk factor for ulceration is the inability to feel a 10-gram monofilament. And actually, in every exam, they ask about monofilament, which you use for assessment of peripheral neuropathy, which is have 10 gram, which is a 10-gram monofilament. 10 gram, actually, this is very simple. I will show this, actually, this one, 10-gram monofilament. This is one. This is the monofilaments used to estimate. This is one. This is the monofilament which we can use to assess the peripheral neuropathy. I will put this image. Okay. This is the 10-gram monofilament which can use to assess this tip can be blended if received a 10-gram pressure. This is a monofilament which used for assessment of peripheral neuropathy, and a risk of ulceration is increased if the patient can not feel this sensation. Less often, the skin is tender, sensitive to touch, which is allodynia. Painful neuropathy affects about 20% of general clinic population. And don't forget that the peripheral neuropathy associated with sleep disturbance, mood disturbance, a loss of quality of life, some wasting of intrinsic muscle of the foot, and the clawing of the toes, leading to Charcot's arthropathy. Mononeuropathy, this is a mononeuropathy, the most common one, which is a cranial mononeuropathy, and it can affect the carpal, leading to carpal tunnel syndrome, and can affect the median nerve, can affect the lateral cutaneous nerve of the thigh. Don't forget, it is a common to involve peroneal nerve involvement, and can affect the foot and leading to foot drop and tarsal tunnel syndrome. A cranial neuropathy, mononeuropathy, this is a very important topic to review. It is a sudden and have a very good prognosis. It is a pulse is the most common, is the nerve 3 and 6 are most commonly, and don't forget that in the third nerve palsy, the pupillary response is intact. Sparing of the pupillary response is usually intact. And this is a mononeuropathy, diabetic mononeuropathy, and the prognosis is very good and spontaneous recovery. A proximal motor neuropathy, which is a diabetic amyotrophy, this is uncommon manifestation, but it is common in the exam, mostly affecting males in their 15 with type 2 diabetes. It is presented by severe pain and paresthesia in the upper legs. Usually affect one limb. It affects the proximal muscle weakness and wasting of quadriceps, and we must do MRI spine to exclude the organic cause, disc prolapse, or another lesion which can cause a similar picture. Improvement usually is spontaneous over 3 to 4 months. Before making diagnosis, we must do MRI scan of the lumbar sacral spine to exclude the other cause. And don't forget, in the diabetic amyotrophy, the patient on oral anti-diabetic drug prefer to convert it to insulin therapy to rapidly improve this diabetic amyotrophy. The foot examination of the diabetic neuropathy, it is a mandatory and the diagnosis, and at least yearly we must test by vibration sensation by 128 tuning fork, by fine touch with a 10-gram monofilament, and we do reflexes. A neurosensometer, this is a very expensive device, or biosensometer. It is not routinely done in the clinics, but in the foot clinic, it is mandatory in this foot clinic. A significant risk of neuropathic ulceration, the patient who is at risk if he cannot feel vibration head of a 25 volt in the tooth. Don't forget that the differential diagnosis of peripheral neuropathy, uremia, vitamin B12 deficiency, infection like leprosy or HIV, toxins like alcohol and lead and mercury poisoning, drugs like chemotherapeutic agents, and malignancy must be differential diagnosis from other diabetic peripheral neuropathy. How to treat? Of course, the asymptomatic patient, the only treatment is good glycemic control. No drugs are yet available for asymptomatic patient. All the drugs available for just painful diabetic neuropathy. And painful diabetic neuropathy, the treatment of painful diabetic neuropathy is not entirely satisfactory, and the treatment may require 6 to 9 months to get a satisfactory results. The most important drugs to use is tricyclic components, a tricyclic antidepressant. The most important one, which is amitriptyline or imipramine, 10 milligram taken at night. Don't forget that a dose can be gradually increased up to 75 milligram per day. The side effects are frequent. Don't forget tricyclic antidepressant have a lot of side effects. Duloxetine, this is another very important drug, which is selective serotonin noradrenaline reuptake inhibitor. And the usual dosage used for diabetic peripheral neuropathy, 60 to 120 milligram per day are effective. But the main side effects of the duloxetine is nausea. So, but this is often self-limiting. It is advisable to start at 30 milligram per day taken with food for a few days and after it, but the effective dose start from 60, not 30. The effective dose of duloxetine is 60 milligram to 120 milligram. And another drugs use can be used for painful diabetic retinopathy, neuropathy is anticonvulsant gabapentin. The gabapentin gradual titration dose, don't forget that the effective dose we start by 100 milligram BD to 1,800 milligram per day, and the effective dose of gabapentin start from 400 to 600. This is the effective dose of gabapentin. And I think there is a consensus statement for peripheral neuropathy published by the American Association guidelines, I think since 2 years, and I will try to put their table in this presentation. And another very important drug to be used in painful diabetic peripheral neuropathy is pregabalin. Pregabalin is very important, but you must know that the starting dose is 75 milligram, and the effective dose, the starting effective dose, 300 milligram per day. We start by small dose 75 milligram BD, increase to 150 milligram BD maintenance dose with a maximum dose. So the effective dose 150 BD or PID twice daily. So the effective dose of pregabalin is 300 milligram daily. Another one, which is antioxidant alpha lipoic acid. This is a not effective drug, just a small trial and not widely used. Just in the Germany, they used it alpha lipoic acid in Germany and some of small localities, but in the UK is not approved for diabetic peripheral neuropathy. So this is a table summarize drugs pharmacological treatment of painful diabetic neuropathy. The only two, which is duloxetine and pregabalin, have been formally approved by EMA and FDA, but according to the NICE guidelines, we can use a tricyclic antidepressant amitriptyline, we can use duloxetine, we can use pregabalin, and also gabapentin. This is the dosage form, and also opiate can be used tramadol and oxycodone and morphine sulfate. This opiate drug is not routinely prescribed. Don't choose one of the opiate drug in the management of painful diabetic retinopathy, neuropathy, because this drug need some of a specialist to prescribe this drug, not us. Also, another cream which is can be used with capsaicin cream applied sparingly, but this is a second choice. The first choice is tricyclic antidepressant, duloxetine, gabapentin, or pregabalin. Also, intravenous lidocaine can be used for refractory painful neuropathy by this dose. General treatment, of course, poor diabetic control appears to be associated with worsening of neuropathy. Also, cardiovascular risk factors like hypertension, smoking, obesity, hyperdyslipidemia must be treated promptly. Another one, which is autonomic neuropathy, and the commonest effects of the autonomic neuropathy is erectile dysfunction, which affect 40% of the males with diabetes, and also this is a multifactorial, not just autonomic neuropathy. It may be a psychological cause. Also, some drugs can cause erectile dysfunction, so it is a multifactorial. Only a small number develops severe gastric upset by using sildenafil, and also cardiac or bladder dysfunction. Abnormal autonomic function test can be expected in 20 to 40% of general diabetic clinic population, which can cause erectile dysfunction. A clinical picture of autonomic neuropathy, erectile dysfunction, this is the most important one. Another one, which is postural hypotension. Don't forget, postural hypotension is autonomic neuropathy, and this is a manifestation of a primary adrenal insufficiency or Addison's disease, giving dizziness and syncope in about 12%. Resting tachycardia or fixed heart rate or loss of sinus arrhythmia, this is a manifestation of autonomic neuropathy. Resting tachycardia, fixed heart rate, loss of sinus tachycardia arrhythmia. As we know, during inspiration, there is a sinus arrhythmia. If this sinus arrhythmia is lost, this is a manifestation of autonomic neuropathy and can be manifested with some special devices. Gustatory sweating, which is a sweating after tasting a food. This is a manifestation of autonomic neuropathy. Delayed gastric emptying, nausea, vomiting, abdominal fullness, constipation, and diarrhea. This is a manifestation of autonomic neuropathy. Urinary retention or overflow, incontinence, anhidrosis, which means absent sweating on the feet, is especially problematic as it increases the risk of ulceration, and abnormal pupillary reflexes. This is a clinical feature of an autonomic neuropathy. How to assess actually assessment of autonomic neuropathy? There is a 4 or 5 question on, I think, on the British Medical Journal on examination or study BRN. I don't memorize which one. Have 4 questions about the assessment of autonomic neuropathy, and I think this is very difficult for me. I actually don't remember how to assess it, but it is abnormality in the normal physiology. And I think in the Oxford textbook of endocrinology have a very important table summarize this, how to assess this. How to assess if autonomic neuropathy is suspected, check lying and standing blood pressure to assess postural hypotension. This is a very simple maneuver by just measuring systolic blood pressure after 2 minutes standing. Normally, blood pressure systolic decreased to less than 10 millimeter mercury drop. If there is more than 30 millimeter mercury, this is abnormal, and this is a diagnostic for postural hypotension. This is a simplest one. A pupillary response to the light, this is done by ophthalmologist. Loss of sinus arrhythmia, as we mentioned during inspiration, the heart rate is different than during expiration. So measuring inspiratory and expiratory heart rate by a special device after 5 seconds of each, normally there is a less than 10 beats per minute difference. This is abnormal. Normally there is more than 15 beats different. But if less than 10, this is a loss of sinus arrhythmia, which is a manifestation of autonomic neuropathy. Another one, which is loss of heart rate response to Valsalva maneuver. This is look at the ratio of shortest RR interval during forced expiration against closed glottis compared to the longest RR interval after it. Normally less than 1.2 is abnormal. And another method to assess autonomic neuropathy, blood pressure response to sustained hand grip. And this actually you need to do hand grip and assess the blood pressure before and after. A diastolic blood pressure rise more than 16 millimeter mercury is normal, less than 10 millimeter mercury is abnormal. And actually, I think in the exam they did not give a scenario and ask about this, but try to memorize postural hypotension, pupillary response to the light, loss of the sinus arrhythmia, loss of the heart rate response to Valsalva maneuver, blood pressure response to sustained hand grip. This is the most important to memorize for autonomic neuropathy. For gastroparesis, you can do a radioisotope test in meal to look for delayed gastric emptying, which is a manifestation of gastroparesis. How to treat usual autonomic neuropathy? We treat only asymptomatic patient, and actually treatment usually is not very helpful or effective. And diabetes control is the most advocated and most important one. Posture hypotension, the most important, how to manage posture hypotension as an autonomic neuropathy, stopping the drugs that may result in exacerbation of posture hypotension, like the diuretic, beta blocker, anti-anginal agents, tricyclic agents, which can cause posture hypotension. Advise the patient to get up from the sitting or lying position slowly and crossing the leg. Increase the sodium intake up to 10 grams per day. Don't forget that a daily requirement of sodium is less than 4 or 5 grams per day. Raising the head of the bed by 10 to 20 degrees. Drinking approximately 500 ml of the water, and pharmacological treatment of fludrocortisone by 100 microgram per day. This is the same for treatment of the Addison's disease. In the Addison's, the normal replacement therapy of or dose of fludrocortisone 100 to 200 microgram per day. In severe cases, we can use alpha-1 adrenaline receptor agonist like midodrine, and also ephedrine can be used, sympathomimetics, octreotide and erythropoietin can be used. So don't forget the general measurement. The pharmacological therapy like fludrocortisone or midodrine can be used for posture hypotension. Erectile dysfunction in libido is not normal affected. So erectile dysfunction, if it is due to the hypogonadism, usually libido is affected. But if it is not due to the hypogonadism, usually libido is intact. Usually erectile dysfunction in libido is not normal affected, and pain is also unusual. Don't forget in the erectile dysfunction, alcohol, tobacco, cannabis, and stress, and some drugs like thiazide and beta blocker, which deteriorate erectile dysfunction, must be stopped or changed. Also, we must do examination for genitalia and for secondary sexual character to assess hypogonadism, and assess the peripheral pulses to search for another peripheral neuropathy, lower limb reflexes and vibration threshold to confirm that the neuropathy is present. And also we must do prolactin assay and testosterone and gonadotrophin before diagnosis of autonomic erectile dysfunction. The treatment usually by sildenafil, starting dose by 25 to 50 milligram, and can increase dose to 100 milligram if needed. And don't forget, it must be taken 1 hour prior to the sexual intercourse, and it is preferred in empty stomach. And another one, which is vardenafil, which is at 10 milligram and can be taken just 25 to 60 minutes prior to the sexual intercourse. And if sildenafil or vardenafil is failed, the next step is using intraurethral alprostadil, and in the exam they ask about these steps. In our exam, the patient failed erectile dysfunction failure after sildenafil. The next step is intraurethral alprostadil. And another one, which is intracavernous alprostadil. This is the same procedure, but it is intracavernous. And the last step is vacuum devices or prosthetic prosthesis. None of this is ideal. Sildenafil, although an oral therapy, is effective only in 60% of those patients with diabetes. Don't forget, sildenafil is contraindicated with severe heart disease and the patient on nitrates or drugs like nitrates, nicorandil, for example. Gastroparesis, and in every exam they ask a question about the gastroparesis, how to manage. The management of diabetic gastroparesis, the most important is glycemic control, stopping drugs that can delay gastric emptying. The most important one is calcium or GLP-1 receptor analog, and also anticholinergic agents like antidepressant can delay gastric emptying and deteriorate diabetic gastroparesis. The most important drug is metoclopramide or domperidone, and another one is erythromycin. In exam, they usually ask a question a treatment in combination with metoclopramide plus erythromycin or domperidone with erythromycin. Another surgical management which is a gastric electrical stimulation or pacing. This is only for drug refractory gastroparesis, which can be used in pacing therapy. Autonomic diarrhea, it is of course diagnosed after exclusion of other organic cause, tends to be worse at night. Alternatively, some may present with constipation alternated with diarrhea. Diarrhea associated with bacterial overgrowth may respond to broad-spectrum antibiotics like erythromycin or tetracycline. Antidiarrheal systemic opioids like loperamide or codeine phosphate. Refractory diarrhea can be treated by alpha-2 adrenergic receptor agonists like clonidine and the somatostatin analog octreotide. This is for refractory diarrhea. In neuropathic bladder, this is a very rare complication of pneumonia neuropathy, and the patient may be presented with a hesitancy of micturition, increased frequent micturition, increase the frequency of micturition, and in serious cases with urinary retention associated with overflow continence. A treatment maneuver include for a neuropathic bladder mechanical method of bladder emptying by catheter, anticholinesterase drug like neostigmine and pyridoxine. A long-term indwelling catheterization is one of option for a neuropathic bladder. This is not actually, this is not a very important topic, and I think I don't see any question about a neuropathic bladder. Anhydrosis, which is a dry fit that cause cracks and a risk factor for infection. We can use creams, may be helpful to prevent this side of autonomic neuropathy. Another one, which is gustatory sweating, which is increased sweating, usually affecting the face and often after eating. We can use some of oral anticholinergic drugs like oxybutynin. And we can use a clonidine. And don't forget that we must search for a systemic lead to investigation of non-systemic approach. And another one, which is botulinum toxins, can be used for treatment of gustatory sweating. This is a slide from Medscape, which is classify types of neuropathy to motor, which is usually not a diabetic, sensory, which is a diabetic retinopathy, usually sensory, in a few cases which can affect the motor, and autonomic, usually large fiber and small, as we know that autonomic neuropathy affects sensory for small fibers, which is for cold perception and pain, and warm perception. Don't forget that a large fibers, which is responsible for touch, vibration, and positional perception, large fiber. And this is how to classification of a small fiber in neuropathy and large fiber in neuropathy. And I think on examination website have some question on small and large fiber in neuropathy. The last topic in our presentation today is diabetic foot. And actually, diabetic foot problems are a leading cause of morbidity. And actually, diabetes is the leading cause of non-traumatic amputation of the lower leg. In every exam, they mention a slide like this. In our previous exam and the two previous exam, they put this slide. In 1 year, they ask about what is this bone, And in another exam, ask about this joint. So try to put this slide in your desk and try to review all the bones in this X-ray foot. This bone, this one, this one, this joint, this bone, this bone, this joint. Every joint in this slide is a question. Every bone and every joint in this slide is a question. So I summarize this slides. I put about 5 or 6 slides about the bones of the foot. Don't forget that this is a calcaneus bone. In the front of the calcaneus bone is the cuboid. In the other part is the talus bone. And in the front of the talus bone is the navicular bone. This joint is talonavicular or naviculotalus joint, for example. This bone is calcaneocuboid joint or cuboid calcaneus joint. Try to memorize it. This is a 3 cuneiform bone, and this is a metatarsal bone, and this is the phalanges. And of course, this is the tibia and fibula. This image is very important. Try to print it and put it in your desk. This is a calcaneus bone, which is a heel bone. This is a talus bone, which is an ankle bone. In the front of the talus, this is a navicular bone. And of course, between them is a transverse tarsal joint or naviculotalus joint. This one. This is a cuboid bone. This is a cuneiform bones. 3 cuneiform bones. One lateral, one intermediate, and one medial one. Medial bone. This is the metatarsal bone, and this is a phalanges, proximal, middle, and distal phalanges. And this is another image for the bone.
Dr. Khalid, can you please show the previous one?
This one. Yes. I will give the joints in another.
Can you please show the previous one? No, before this.
This one? Or this? This or this? Or this? This one?
Yes, noted. I had to take the screenshot,
Yes. I will upload the PDF file and the recording, Dr. Ruben. In every exam, they will put this image and ask about some of the joints and the bones. And this you can, don't forget, this is a talus, this is a calcaneus, this is a cuboid, this is a navicular, this is a cuneiform. Try to memorize it a lot of times, especially before the exam. And it is very simple, and its question is very simple actually. And this is another sagittal and from another review for the joints and bones. And this is for joints. And actually, this is most important for the joints. Mute voice, okay, Dr. Najah. Sarah and Dr. Salwa. Okay. A risk factor for foot ulcer development, several factors predispose to ulcer formation. So if the patient have a risk factor, just label it as a diabetic foot with a risk for foot ulcer. Peripheral neuropathy is one of the most important risk factors for development of foot ulcer. Reduce the sensation of 10-gram monofilaments, one of the earliest risk factor for development of foot ulcer. Reduce the vibration perception threshold. Autonomic neuropathy and hydrosis can dry out the skin and leading to diabetic foot ulcer. Motor neuropathy, peripheral vascular disease is very important and very important risk factor for development of foot ulcer. And don't forget how to assess peripheral arterial disease by doing ankle brachial artery ratio. If it is more than 1.5, it will suggest peripheral arterial disease. A very important risk for development of diabetic foot ulcer is duration of the diabetes. The presence of other microvascular complication is a risk factor, and one of the most important risk factors is previous ulceration. Previous ulceration is the most important risk factor for development of a new foot ulcer. A lack of diabetes monitoring in mechanical and chemical or thermal trauma injury in the foot is a risk factor. The prevalence of foot ulceration in the UK is about 5 to 10%. The number of people with diabetes with foot ulcer, this is just a number. The most important prevalence of foot ulcer is about 5 to 10%. How to differentiate between a neuropathic feet or ischemic feet, which is a peripheral arterial disease? A neuropathic feet usually warm, ischemic cold or cool. A dry skin in the neuropathic feet, but atrophic, often hairless in the ischemia. Palpable foot pulses, no palpable foot pulses because it is ischemia. No discomfort with ulcer, more often tender and painful ulcer. Callus present in neuropathic feet, claudication and wrist pain in the ischemic feet, and also skin blemishes on the elevation and redness on dependency. And this is a vaginal classification of diabetic foot lesions, and I also try to put this image for vaginal classification. Grade 0 for the patient on high risk foot, no ulcer, but this patient is diabetic, so this is a high risk for foot ulcer. Grade 1, this is a superficial ulcer, not infected. Grade 2, deep ulcer like this, with or without cellulitis, but no abscess or bone involvement. Once a deep ulcer which involve abscess formation or osteomyelitis, so it is a grade 3. If there is a localized gangrene like this, it is a grade 4. If it is a whole foot gangrene, it is a grade 5. This is a vaginal classification for diabetic foot lesion, and this image is very helpful for classification. And also this is another image for vaginal classification. This is a grade 0, this is a grade 4 because this is a localized gangrene. This a whole foot gangrene, so it is a grade 5. This is a deep ulcer with infection and osteomyelitis, so this is a grade 3. This is a superficial ulcer, no infection, so it is a grade 1. And this is a deep ulcer, so this is a grade 2. A treatment of diabetic foot, of course, a treatment is aimed at several disc area. The patient who is at high risk with no current ulceration, or so if there is existing or infected ulcer, we must treat it. Osteomyelitis must be treated promptly. And vascular insufficiency must be treated as a peripheral vascular disease. The patient at risk, feet with no current ulcer, it is a general measurement and education of our patient, a general advice on the nail care, hygiene, and care with a footwear. This is a very important. Actually, it prevents a lot of diabetic foot ulcer. And one of the most important, regular daily examination, try to reinforce and educate our patient to regular daily examination and the regular podiatry review, and consider the need for modification of footwear or special footwear if indicated, and also avoid the walking barefoot. This is for patients who are at high risk for development of ulcer. No other therapy is advocated in this group. If there is existing ulcer, we must optimize the diabetic control. لا فوقيه، لو الشال راح يفصل كهرباء من عندي، فبعد عدي من فوقيه او من تحتيه وانتبه انه يتخلع من عندي. لا عدي من فوق. صوتي مسجل كده. اوكي. المانجمنت اوف existing ulcer, optimizing the diabetic control, reduction of the edema is important to aid the healing, regular debridement of the callus and dead tissue skin, this is very important and can be done by diabetologist or vascular surgeon. Infection control is very important. The most important causative agent is Staphylococcus aureus or Streptococci. This is the most causative agents for diabetic foot infection. Don't forget, if a sinus is present, we try to probe it to detect if there is osteomyelitis or not. And we must do Blair radiograph, which is the first imaging modality if there is a sinus to diagnose osteomyelitis. Also, radioisotope scan using a technetium can show increase in uptake. Also, post-infection and Charcot arthropathy. Also, MRI scanning can be used to differentiate in this situation. A treatment, اتبه السلك يا مريم بعد اذنك. الانتيبيوتيك recommendation, it is commonly used triple antibiotics, flucloxacillin, ampicillin, amoxicillin, metronidazole. This is one option. Another option is co-amoxiclav, which is clavulanic acid plus amoxicillin. Another one, ciprofloxacin plus clindamycin. This is a 3 options for management of diabetic foot infection if indicated. Don't forget that this is by oral route. If there is a severe infection, we must use intravenous treatment. For osteomyelitis again, we must refer to local guidelines. We can use ciprofloxacin or sodium fusidate. Don't forget, we must reduce trauma and pressure relief. If there is ulcer, we need to do total contact cost may be needed. Don't forget that in a case of peripheral arterial disease, revascularization may be needed, and the periphery we can, if there is a gangrenous, we may need amputation, which is usually below knee procedure to give a better immobilization potential post-operatively. Charcot foot, this is, I think, the last topic today, just 2 or 3 slides today. Charcot foot, usually it is a rare complication. Pathogenesis, osteoclast activity, and bone turnover to increase. Charcot arthropathy usually affect the mid of the foot. Clinically, the most likely site is tarsal, metatarsal region. Don't forget, this is the most affected joints for the Charcot arthropathy. Tarso-metatarsal joints. Tarso-metatarsal joints, this joint. Or metatarsal phalangeal joint, which is this one. Initially, it gives a warm or hot, swollen, and uncomfortable foot, which may be indistinguishable from cellulitis and gout. Peripheral pulses are invariably present, and peripheral neuropathy is evident clinically. This is how to diagnose Charcot arthropathy. It affects the tarso-metatarsal region and metatarso-pharyngeal joints. A Blair radiograph will be normal initially, but later on show fractures, which osteolysis and joint reorganization. The isotope scan with technetium are abnormal from the early, but differentiation from infective or other inflammatory cause can be difficult, and MRI scan may prove more useful for this feature. And this is how to differentiate between active Charcot, which affect the mid of the foot, and the osteomyelitis, which affect the forefoot and hind foot. This is usually hot, red foot, and no ulcer in the active charcot. In osteoarthritis, there is ulcer with hot, red foot. It affects the forefoot and the hind foot, the calcaneus like this, or the front of the foot. But the active charcot, as we mentioned, it is a mid-foot subarticular. The X-ray in both condition usually normal. The MRI will show in the active charcot marrow edema in the mid-foot subchondral, and on osteomyelitis will show marrow edema in the forefoot and hind foot near ulcer. How to manage charcot foot? Usually immobilization. If diagnosed early, immobilization may help to prevent the joint distraction. We need exactly how best to do this is not agreed. By using a non-walking plaster cast or air cast type of the foot is needed for at least 2 to 3 months. The management of charcot arthropathy, immobilization, casting. The use of bisphosphonate does not seem to alter outcome. The main management of charcot arthropathy is immobilization. And I think this is my YouTube channel. This is the last slide, and this is my phone number and WhatsApp number. This is the last slide in my presentation.
Khalid, thanks a lot. This is really a very good presentation.
Thanks, Dr. Ruban. If anyone wants anything, I think if anyone wants PDF files, other files, I can send it. I think in all groups it is available, but if anyone cannot find them, I can send it by WhatsApp number. Okay. Inshallah, in the next session, inshallah, in the next week, we will finish diabetes and dyslipidemia. And after that, we have already الجنادل chapter. Inshallah, I will upload the PDF file for this presentation, and also I will upload it to the YouTube channel. Thanks everyone. أشوفكم على خير. السلام عليكم.
Thank you very much.
خلاص.
بتقرا الاعجابات يعني؟
لا أنا عملت
عملت ايه؟
دقيقة واحدة بس.